Today's session will explore the role of foster youth core health team as well as how to make the most of services like transitional care management and enhanced care management. A couple of quick housekeeping notes before we get started. Today's session will be recorded and will be available on our CFPIC website, where you can also find past Lunch and Learn sessions, as well as a range of helpful tools and resources. We will drop our website here in the chat. Also, at the end of the session, we'll share a short survey, and we'd really appreciate if you could take a moment to fill it out. Your feedback continues to help shape future sessions. For today's Lunch and Learn, we are fortunate to have Dr. Lock Wynn. Dr. Wynn has been a child welfare policy consultant with the County Welfare Directors Association, otherwise known as CWDA, since the beginning of 2018 and is currently the CWDA representative to the state technical assistance, helping counties to address the needs for foster youth with the most complex needs. He has worked with vulnerable populations for more than 37 years, including refugees, the elderly, those affected by disasters, and children. He has held various roles in public child welfare field since 1999, including as an assistant regional administrator for the Los Angeles County Children and Family Services, the director of the Regional Training Academy for Los Angeles County, and was the child welfare director in San Mateo County for more than 5 years. So we are in great hands today. Thank you so much for being here, and I will turn it over to you, Locke.
Good afternoon, everybody. So we're going to do, after a bit of welcome, talk about some definitions and concepts, talk about pre-CalAIM, then talk about CalAIM, basic population health management, complex care management, enhanced care management, and then CalAIM and foster youth. So CWDA is the nonprofit that represents the human services directors in the 58 California counties. And I'm really proud to be a part of an organization that's actually been working with the welfare of all Californians for about 100 years now. And part of my role is to be able to provide consultation and technical assistance to counties and their partners on navigating very complex issues of youth who are in foster care, not only mental health issues, but also their physical and other health needs. And what you're going to hear today is a little bit of that technical assistance to see how we might be able to better help assist these youth and their families. So, a few definitions and concepts. A managed care plan or managed care organizations in other states is an entity that manages the health care of a beneficiary. They do this by collecting premiums, and then they contract with providers to manage the health of that beneficiary. The original premise was actually to protect a person's income from adverse health issues. So often these plans were tied to a person's employment, and they've been around for a long time. Anthem Blue Cross and Blue Shield since the 1930s, and Kaiser Permanente since the 1940s. And by the 1960s, it was recognized at the national level that not all people, even those who were employed, had access to Medi-Cal managed care plans. And so in 1965, Medicaid was created. It focused on poor individuals who were eligible for certain federal benefits. It was administered by states under federal rules, and there was cost sharing and financing between the federal government and the states. And pretty much states manage their own Medicaid plans. It's known as Medi-Cal here in California. And if a beneficiary moved to another state, they'd have to apply to a new Medicaid program in that other state. So the Medi-Cal fee-for-service concept is that beneficiaries are really responsible for finding their own primary care doctors, specialists, et cetera. There's really no one to match them to a health provider. And the Department of Healthcare Services establishes schedules, negotiates rates with providers, determine the medically necessary criteria, and pays provider claims. California was actually the first back in the 1970s to provide a Medicaid managed care model. And in the 1990s, in response to really rising fee-for-service costs and concern about access to care, California really expanded its effort to enroll a significant portion of the Medi-Cal population into managed care. A little bit later, I'll share with you some statistics about how many are actually enrolled. While managed care plans differ by counties, each of the participating managed care plans contracts with DHCS and assumes the financial and risks for all covered services. So there are a few differences. For straight Medi-Cal, it's statewide. For managed care plans in 40 counties, a beneficiary has to enroll in a single managed care plan. For the other 18 counties, they have some choice. In terms of the actual provider, beneficiaries can go for straight Medi-Cal. Beneficiaries really can go to anyone who accepts Medi-Cal, but there's no directory. For managed care plans, they have to provide a directory. And there's exceptions if the service is not available within that directory. And in terms of screening and preventative services, the state doesn't ensure that providers offer the screening or preventative services under managed care plans. They have to provide screening and assessment services. In terms of transportation for straight Medi-Cal, it is available and it is a covered benefit, but there's no assistance to secure that benefit. Managed care plans have to provide the service and have to help coordinate the transportation. Language interpretation, it has to be made available under straight Medi-Cal, but there's no state monitoring for that. Managed care plans must make language interpretation available. And there are a number of other sort of differences between the two, and there seems to be more benefits under managed care plans and whatnot. So primary residence, this is sort of the key, one of the definitions. Primary care residence of a child in the context of managed care plans is the county where the parent resides. It doesn't change if that child goes on vacation, if they go to summer camp in another county, if they end up enrolling college in another county. And if the beneficiary moves to another county, they have 30 days to choose a Medi-Cal managed care plan unless there's only one managed care plan in that particular county. So primary care provider is really the main health care clinician, usually a physician for the beneficiary. And this is the person, this is the go-to, right? They are part of a core health team. They address a person's preventative health care, including annual physical exams, arranging for yearly vaccines, and even to be able to be the point person to refer a beneficiary to specialists should they need more care. Specialist is a health clinician with additional training and expertise. It could be a pediatrician who's a physician that specializes in the health of children. It could be a child psychiatrist, a physician with expertise in psychiatric issues among children. They don't necessarily have to be a physician or even have a doctorate. You might be a licensed clinical social worker, a person who has a master's degree in social work and is a licensed mental health clinician. So consultation is a request from one healthcare provider to another for advice. So a primary care doctor might try to get the advice of a child psychiatrist. A referral is a request from one healthcare provider to another to manage one or more health conditions. And that other provider will be responsible and will be the lead for all aspects of that particular condition. So let's say the psychiatric components might be referred to a child psychiatrist, and they would be responsible for the psychiatry piece, while the primary care doctor still handles the primary care for the youth. A transfer of care occurs when one healthcare provider turns over all of that responsibility for comprehensive care of a patient to another healthcare provider. It could be temporary, like when a child is hospitalized, or it could be permanent. Let's say a beneficiary moves from San Diego to Shasta County. Core health team includes a primary care provider as the lead health clinician, and it also can include others. including a nurse practitioner, a nurse, a pharmacist, a social worker, and so on and so forth. Sometimes a primary care provider could refer the beneficiary to additional specialists, like a child psychiatrist, and then have that specialist join the core health team should the need arise. Inpatient means that a doctor, healthcare provider, or a facility has contracted with a managed care plan to provide services based on agreed rates. Out of network basically means that an entity has not contracted with a managed care plan and they set their own rates. So outpatient services are usually those that the beneficiary receives outside of the hospital, usually does not require an overnight stay. It can include things like an annual visit to your primary care provider, getting vaccines, lab tests, outpatient surgery. It could be a stay in a short-term residential treatment program or community treatment facility. It can also include an emergency room visit where they might have to stay overnight, but the doctor has not admitted them into the hospital yet. Inpatient services are related to when a beneficiary has been admitted into a hospital or other inpatient facilities. And it usually includes healthcare staff that are part of the formal inpatient, creating formal inpatient treatment programs and are monitoring a beneficiary on site 24/7 for days, weeks, sometimes months. So basic services like going to get your annual physical, getting vaccines, don't really require prior authorization, but there are certain services, especially specialized services, and certain medications that require prior authorization or pre-authorization. It gives the ability for a managed care plan to determine if those services are medically necessary. Timely access standards. This is the maximum time period in which Medi-Cal or other beneficiary has have access to contracted services once referred or an appointment has been requested. So urgent care, no more than 48 hours. Primary care, no more than 10 business days. Specialty mental health services, no more than 10 business days. And psychiatry services, no more than 15 days. I see that there's a hand raise, and if you could put your question into the chat, we'll make sure to get to it, if that's okay. The maximum, so network adequacy standards is the maximum distance or travel time availability of a service in relation to a beneficiary's primary residence. So for primary care, hospital, pharmacy, within 10 miles or 30 minutes of the primary residence, and psychiatry or specialty mental health services, it can vary by county. Sometimes it's 15 to 30 minutes within a primary care residence, or in some of the more rural or remote areas, it's about 60 to 90 minutes. Continuity of care. One definition is the ability to stay with a provider or get the same level of services at no additional cost or pre-authorization. A specified amount of time, regardless of where you move or if you have changed Medi-Cal managed care plans. And in the community, a beneficiary has to request this continuity of care, but can actually get up to 12 months of continuity of care, especially if they move to a single planned county. The other definition is a continuum of levels of healthcare for a beneficiary. This will involve either outpatient or inpatient services. It would start with an initial visit to a beneficiary's primary care provider. And as you can see here, it could be sort of levels, outpatient, intensive outpatient, partial hospital program, residential outpatient, residential inpatient, hospital, and it can go the other way as well. So examples in the mental health world of a continuum of care for outpatient is regular office visits with a mental health clinician, intensive outpatient, wraparound is an example, partial hospital program. There's one designed for mental health. There's another designed for substance use disorders, residential outpatient, the short-term residential treatment programs or community treatment facilities, residential inpatient, psychiatric residential treatment facilities. They don't yet exist or have a physical structure yet, but the interim licensing standards has already been drafted. And then hospital inpatient can be acute psychiatric hospitals. Now, sometimes you might skip certain steps. So it's not this layered aspect of it where you can start with a visit with a mental health clinician and you might end up at some point in a psychiatric emergency. And then when you come back out, you're visiting with that clinician again. In foster care, you might have regular visits with a mental health clinician, then wraparound, then maybe a stay at an SRTP. Some youth have ended up in a psychiatric emergency, and then they transition out or step down back into an SRTP and then step down back into the community and receive those services. So transitional care services are essentially those that relate to when a beneficiary is admitted into a healthcare facility, like a hospital, transferred from one facility to another, or discharged from a facility. And it's available to all beneficiaries in Medi-Cal managed care plans. And while it existed before CalAIM, it's not as robust as it is today. And I'll talk about it a little bit later. So an example, pre-CalAIM, you might have parents who have a sixth grader who are all on Kaiser managed care plan, and they move from San Diego to Shasta, which only has one Medi-Cal managed care plan, which is Partnership Health Plan of California. In San Diego, the youth had asthma, and they were actually referred to a pulmonologist, which is a physician who specializes in respiratory issues, who had prescribed some asthma medication. The parents then asked their child's primary care provider in San Diego to help with this continuity of care, including making sure that records, medical records and whatnot are transferred, as well as the ability to access that pulmonologist via telehealth and any medications without needing prior authorization. So they identify a potential primary care provider to transfer their case up to Shasta. And after a year, they have asked their primary care provider also for a referral to a local pulmonologist up in the Shasta area. When the child was in the 9th grade, they had a really bad car accident. The child was transferred to UC Davis. It actually has the only level 1 trauma center in Northern California for both children as well as adults. And partly because they had multiple broken bones in their legs because of that car accident. So the parents contacted the managed care plan to get assistance for transitional care services, as the child had to be admitted for several weeks. Care is formally and temporarily transferred to UC Davis with the orthopedic surgeon and their team. And then after several weeks, the managed care plan assists with transitional care services to help get the youth discharged. And one of the first recommendations on any hospital discharge plan is for the youth to meet with their primary care doctor. In addition, there are recommendations for referral, which needs prior authorization for physical therapy for the youth, as well as the ability to see that UC Davis orthopedic surgeon for a few more times for follow-up. By the 10th grade, they've fully covered from their physical injuries. And then they go to UC San Diego for their freshman year. And as their parents still have primary residence in Shasta, they'll keep the primary residence with Partnership. The youth also has minimum double coverage, double health coverage with UC San Diego Health Center, as it's a part of their registration fees. Right after freshman finals, the youth goes out, celebrates with their friends, end up in a bad car accident. Luckily, no one is physically hurt. However, that youth has a psychiatric episode and response, which leads to a 5150 admission into Rady's Children's Hospital in San Diego. And the parents notified the managed care plan Partnership for transitional care services, assistance, and partnership coordinates with Radies on the discharge plan and the youth is released. Part of the discharge plan is to consult with the youth core health team as soon as possible and actually make a recommendation for referral to a child psychiatrist. Youth is discharged and goes home for the summer, and the parents ask the primary care provider for that referral to a CAP, a child and adolescent psychiatrist, who in turn recommends a referral or transfer to a short-term residential treatment facility in the Shasta area. The SRTP is overseen by Shasta County's behavioral health, and their specialty mental health services is overseen by the SRTP child and adolescent psychiatrist, and the youth primary care is still handled by the youth primary care provider. And once discharged before the summer is over, the youth's regular child and adolescent psychiatrist then works with the youth on non-specialty mental health services. So we have to ask, if all of these systems are in place, why did the Department of Healthcare Services in 2018 and 2019 pull in stakeholders and experts from all over California to reimagine Medi-Cal, specifically Medi-Cal managed care? What was the fuss about? Right. So after 50 years of working with Medi-Cal managed care, the state and others recognize a number of issues, 6 of them. The first was that people in the population have different health needs. And some have low health needs, others have higher health needs. And you can actually begin to categorize health needs by level. So 80% of all beneficiaries have low health needs. In essence, they were healthy all the time. And about 15% of all beneficiaries had moderate to high health risks that required some type of intervention. They might have that asthma, they might have type 2 diabetes, but it was very manageable. There's about 5% of the population, 5% of beneficiaries who have very high risks. They might have cancer, very serious mental health issues, et cetera. The sort of second insight was that 5% of the population led to about more than 50% of the healthcare costs and resources within the Medi-Cal world. So an example of this is that foster youth represent less than 4% of the entire child population on Medicaid, and yet they account for more than half of the psychology visits, nearly half of all psychiatry visits, about 4 in 10 of all inpatient public hospital stays, and more than a quarter of all psychiatric inpatient hospitalizations. The third insight was that the determinants of health outcomes, especially for those with very high risk, were not biological. They weren't due to bugs. They weren't due to viruses or bacteria. It was actually due to something called social determinants of health. In essence, social determinants of health are the conditions in which people are born, grow, live, work, even age, which can then affect their health. Right? So research has shown that job loss, food insecurity, housing instability, homelessness leads to increased adverse physical and mental health issues, especially in children. Being uninsured, just the fact that you're uninsured, leads to poor health and increases the chance of premature death by 25%. This was partly due to the fact that people without insurance waited for as long as possible to get healthcare because it was too expensive. And for some, unfortunately, they waited so long that their severe health issues could no longer be addressed. This is why a lot of us in the public health field are really concerned when you hear that millions of people have lost access to healthcare at the national level. Right? Of the ACEs, adverse childhood experiences, 6 in 10 of the questions relate to abuse and neglect as children. And research has shown that severe adverse health effects start at a score of 4 or greater. So in essence, with a score of 4 or greater, you're 2.4 times as likely to get cancer, 3 times as likely to get diabetes, more than 3 times as likely to get heart disease, 3.5 times to get respiratory diseases, and nearly 6 times as likely to get a stroke. Those with at least 4 ACEs die an average of 15 years younger than those without, And if you have an ACE score of at least 6, you're likely to die on average 20 years younger. One of the most striking statistics to me is that even if you don't have ACEs and you have a family member that does have ACEs, you're twice as likely to die prematurely. The fourth insight was that while the doctors, nurses, and other healthcare professionals are an important part of addressing social determinants of health, most of the resources, most of the effort will have to come from the community where the person lives. This includes not only human services agencies, but also community-based nonprofit organizations and other non-healthcare providers. Right? A benefits analyst in the human services agency will reduce the likelihood of an early death for 1 out of every 4 people they sign up for health insurance. Child welfare and probation staff lessen the likelihood that ACE scores increase when they are working with youth and their families. Nonprofit agencies and other community partners reduce adverse social determinants of health outcomes by helping people secure food, jobs, housing, etc. So the fifth insight was that these level of health risks, you can create a system around them. So for the 80% who have low health risks, you can utilize population health management. For about 15% of the beneficiaries who have moderate to high health risks, you're going to utilize complex care management. And then for the 5% of the beneficiaries, you're going to be utilizing enhanced care management, which is by community-based providers rather than healthcare providers, and are usually non-healthcare related. The sixth insight in terms of capacity was that in terms of population health management, the infrastructure was already in place. Yeah, we needed to tweak it and whatnot. Complex care management, we needed to tweak it a little bit more, but the infrastructure was still in place. Enhanced care management, unfortunately, the infrastructure was not built. So we needed to be able to build that capacity almost from scratch. What California then did was to commit $1.5 billion over a 2.5-year period to build out enhanced care management and community supports. And so DHCS has created policies for these 2 particular areas. And really, the context and the definition that is central to the conversation around CalAIM is beneficiary patient-centered care. What this essentially meant was that while it was a part of CalAIM, it took new meaning and it was reemphasized to a whole new level with CalAIM coming about. In essence, planning, delivering, evaluating healthcare was based upon partnerships between the beneficiary, their family, and the healthcare provider. It was no longer about this old question of what is the matter with the beneficiary and patient, but there's now a newer concept in which we're now focusing on what matters to the beneficiary and patient, right? How can we help the youth and their family with the youth's own healthcare journey? Now, I will have to say that there are parallels within the child welfare system, and a shout out to our state technical assistance teams, because they will always ask or re-ask one of the questions that child welfare supervisors and their social workers as part of integrated core practice model will always ask. In essence, what does the youth want? What is important to them? What matters to them? So risk stratification, segmentation, and tiering is the idea that you can differentiate members into different subgroups. It has to occur each time a member is enrolled, annually after the enrollment, and upon any significant change in health status. So examples could include those entering complex care management or enhanced care management, children and youth with special healthcare needs, in essence, children with at least one chronic or physical or mental health issue, currently residing in an acute hospital setting, hospitalized within the last 90 days, 3 or more hospitalizations within the last 12 months, 3 or more ER visits, emergency room visits in the last 12 months. within the last 90 days prescribed an antipsychotic or more than 15 prescribed medications of any type. Okay? All of these and more should trigger an additional assessment to determine whether or not a beneficiary needs to be able to be reclassified into a higher level of care and need and risk. So basic population health management. Every beneficiary, doesn't matter what their risk level is, receives basic population health management. This means that they'll have a primary care doctor as well as primary care and referrals to others as warranted. Even though, and this is an important slide, even though Medi-Cal services, some Medi-Cal services are what are called carved out, like specialty mental health services, managed care plans must ensure that members have access to needed services that address all of their health-related needs. So it doesn't matter if it's developmental, physical, mental health, SUD, dementia, and so on and so forth. Another important slide is that each beneficiary is assigned that primary care provider who plays that key role in coordination of care. Okay, so in essence, continuity of care starts with the beneficiary's primary care doctor, regardless of what insurance that beneficiary has. So here's another important slide, and it is not optional. It is not a recommendation. It is an absolute expectation from the Department of Healthcare Services that managed care plans must coordinate health and social services for children, for any beneficiaries who are under 18, going between settings of care and across other delivery systems. Specifically, managed care plans must support children and their families to access medically necessary physical, behavioral, including specialty mental health services, developmental, dental, and on and on and on, even social and educational services. Now, this doesn't mean that they're going to supplant anything that is in place, but it's the recognition that people go from one system to another, right? In essence, sometimes children will move between systems. Sometimes they will step down from a higher level of care back to their homes in the community. DHCS has then said the best entity to coordinate this continuity of care is the managed care plan with the primary care provider as the lead. So if you have complex care management, every beneficiary who's signed up for CCM will be assigned a CCM care manager who will work with the beneficiary to develop a case management plan, which I'll talk about in a little bit more in a moment. And for children under 21, they must, CCM must include EPSCT, early periodic screening, diagnostic and treatment. And if the beneficiary needs transition care services, the CCM care manager will take on that role of the TCS care manager. So services should include care coordination on longer term issues, transitional, transitory issues like, or episodic issues like being hospitalized, something that is temporary, disease specific management programs, and community supports if available and medically appropriate. So enhanced care management went live January 2022. And the idea is that it's a community-based, interdisciplinary, high-touch, person-centered approach and provided primarily through in-person interactions. The initial authorization for any beneficiary with enhanced care management is 12 months, and then it has to be reauthorized every 6 months thereafter. Managed care plans are required to contract with community providers, and those providers will then assign a ECM lead care manager to each member. And this lead care manager meets with the member wherever they are. They can be at home, they can be in the street, they can be in a shelter, it can be in a doctor's office. Okay. There are a number of populations who are automatically eligible for enhanced care management, but not automatically enrolled. I'll point out 3 of them. So one subpopulation is anyone who receives specialty mental health services. And this doesn't matter if you're a foster child or not. Okay. And so if you're a child or if you're a young person and you're receiving specialty mental health services, you qualify for this subpopulation. If you're receiving drug medical services, DMC, another subpopulation are those that are hospitalized a lot. And a lot means within the last 12 months, a beneficiary has been admitted into a hospital 2 or more times, or they have had an ER visit, an emergency room visit, within the last 12 months of 3 or more times. For foster youth, anyone who's under 21 and is receiving foster care in California, under 21 and previously received foster care in California or another state within the last 12 months, having aged out of the foster care system up until the age of 26 in California or another state, are under 18 and eligible for and or in California's Adoption Assistance Program, and anyone under 18 and are currently receiving or have received California's Family Maintenance Services and Program within the last 12 months. So here are a number of goals. As you can see, it includes care coordination, integrating services, and even addressing social determinants of health. And there are 7 core components: outreach and engagement, comprehensive assessment and care management plan, enhanced coordination of care, health promotion, comprehensive transitional care, member and family supports, and finally, coordination of and referral to community and other social support services. So, per timely access standards, right? Once a beneficiary is deemed eligible for ECM, the managed care plan has 10 business days to refer that beneficiary to an ECM provider. And unless that provider does not have capacity, they will immediately accept the beneficiary and assign them an ECM lead care manager. This care manager then is responsible for coordinating a beneficiary's enhanced care management as well as community supports through the development of that care management plan. Okay, so there's redundancy in the system. If, for example, they don't have a primary care provider, the ECM lead care manager will help the beneficiary to be assigned a primary care provider. If the beneficiary needs transitional care services, the ECM lead care manager will become the beneficiary's transitional care services manager. And while there are no network adequacy issues, right, because that ECM lead care manager is supposed to meet with the beneficiary wherever they are in terms of that, and they'll help develop that case management plan. So I sometimes say, to have them refer to that and then create this plan. And what is this plan? So a care management plan is a comprehensive, individualized, person-centered care plan developed for the beneficiary, by the beneficiary and their parent, or whoever has care, custody, and control, with appropriate clinical input, including from the core health team. The care plan is supposed to incorporate the desires of the beneficiary, addresses their needs across all spectrums of healthcare, and it has to include goals. What is to be monitored? Identify services and service providers, those that are in place, those that are needed, and then the timeframes of when to follow up with the beneficiary, as well as when referrals are going to be made to those providers. A copy of this care management plan has to be given to the beneficiary, and if applicable, to their parent or whoever has care, custody, and control. So the concept here, again, it's not this aspect where a beneficiary just pushes it off to a care manager, an ECM lead care manager to develop everything. They are an integral part of the creation of their own plan and whatnot. So the difference between CCM and ECM, they cannot be enrolled at the same time. Rather, CCM is considered on the ECM continuum of case management. And DHCS encourages managed care plans to work with providers to contract for care management continuum of ECM and CCM programs, including if one provider can actually do both. So transitional care services, managed care plans are expected to use consistent assessment process and tools to identify members who are likely to suffer adverse health consequences upon discharge without adequate discharge planning. Many of you have heard me say this, but in the context of what is called Health and Safety Code 1262.5, which requires hospital discharge plan evaluation on top of the hospital discharge plan. So managed care plans actually have to know in a timely manner of admission, discharge, and transfer, not only from a hospital, but also from a residential treatment facility or incarceration facility, which I highlighted here. So residential and treatment facility, short-term residential treatment programs or community treatment facilities. Incarceration facilities, juvenile hall. This is not the law enforcement side of juvenile hall, but the healthcare side of juvenile hall. So for TCS, transitional care services, you have to have a care manager. Those who do not have a care manager, they may decide to choose their own, etc. And the MCP can actually contract with a hospital or primary care provider or another appropriate delegate for that. They must identify and notify the responsible care manager of the assignment of the member's admission and location of admission into one of these particular facilities so that they can begin to help the case planning. And they must also ensure that the member has the care manager's contact information. For members, and here's the recognition, sometimes you'll say, well, why would managed care plan be responsible for transitional care services if they are in an acute psychiatric hospital or an SRTP, et cetera? There's a recognition that normally those facilities will be responsible for that in working with county behavioral health. However, it's also recognized that mental health plans have very limited access and ability to coordinate across all managed care plans or even address physical healthcare needs. This is why the managed care plans have to assign a transitional care services manager to coordinate with behavioral health and other county care coordinators to access those other services like ECM or CCM. Here are a few of the community supports. Right, and I'm going to quickly talk about 3 of them. And you have caregiver respite services. These are provided to beneficiaries and members who require intermittent temporary supervision, right? Because of the need for them to get respite. And the example of this is a relative resource parent in family reunification who might request short-term respite. Another example is medically tailored meals or medically supported foods, right? They're designed to address an individual's chronic or other serious conditions. Think type 1 diabetes, right? You might be able to create medically tailored meals or even develop medically tailored groceries and items so that a person can cook for themselves, but within the appropriate context of their health issues. Then personal care and homemaker services. It includes things that are similar to IHSS, but this last piece I really highlighted so that you're aware that the interpretation could be an aid to help to help the relative resource family with the supervision of a foster youth with mental health issues who may be trauma triggered and they tend to leave the home often in the middle of the night, say. Community health worker services. I'll talk about it a little bit later as well. Or I have a link to that. And it is a benefit. It can be a part of ECM and community supports. And they are known by many names. They provide services, a number of particular services, and here they are. They can provide health education, health navigation, screening and assessment, and individual support and advocacy. How does one get referred? Well, a licensed provider, like your primary care provider, doctor, can refer you. over to a community health worker and whatnot. I just wanted to mention one thing specifically for protections around continuity of care for American Indian beneficiaries. And primarily, they can actually access out of network services without a contract or without needing prior authorizations. So, this is one of the main things. There are others as well. So, DHCS recognizes that, especially for those who, what we might call ICWA eligible youth, they have additional protections on top of everything else as well. So most Californians who are on Medi-Cal are actually enrolled. By the beginning of 2019, around 80%. And then as of December 2025, more than 97% of the 14.3 million beneficiaries are enrolled in Medi-Cal managed care. Right. So before I put the youth in context, by the time that I had joined LA County DCFS in 1999, both my parents had 43 years of combined county experience between them. They also had their MSWs, and that's a whole nother story in and of itself. But one of the nice things about being as a part of a county family is that I had Kaiser as my healthcare plan. However, for things like dentistry and optometry, they were considered carve-out services because Kaiser did not offer them. Okay, and what it essentially meant was the employer purchased a portion of the health services from a specialized vendor. So if I needed optometry, I can get I can utilize the equivalent of VSP or eye insurance and go to any optometrist. Same with dentistry. I have Delta Dental and so on and so forth. Specialty mental health service is another type of carve out. And normally the funding is capitated. And in certain conditions, it can be very expensive. So the services are carved out or given to another system to address. So a few more things for definitions for foster youth. Primary residence of a foster youth before termination of parental rights is where their parents reside. Primary residence after termination of jurisdiction is the county where the court terminated jurisdiction. In both cases, it's essentially the county of jurisdiction, and this does not change for foster youth, even if they're placed outside of the county of jurisdiction. Care, custody, and control is with the social worker, and there's actually similar language under probation. And the healthcare decisions is actually covered under WIC 369C. So it actually includes things like the ability to decide on a Medi-Cal managed care plan. And again, there's similar language for probation under this particular WIC. So the rules are that if a child is not yet on a Medi-Cal managed care plan, they can't be required to enroll in that plan. And it's the responsibility of the county in consultation with the child and family team to determine what is in the best interest of the child. Okay. If the youth is placed outside of the county, again, the county in consultation with the CFT will determine whether or not it's best to keep the youth on the current managed care plan or to change plans. If a foster youth stays on the same plan, the managed care plan shall process the claims and whatnot. And if for whatever reason there is a disenrollment from a plan or moving from managed care to fee-for-service, the county actually has to provide 10 days of before any notice of any action affecting Medi-Cal benefits. All right. So continuity of care was in what's called an all-plan letter 24014. It basically says that continuity of care for a foster youth can be made 60 days before the transition and has to be processed within 5 days. And then processed within the certain timeframes, 30 days for a non-urgent request, 15 calendar days for those that need more immediate attention, And then as soon as possible, but no more than 3 business days if it's very urgent, right? Potential immediate harm to the beneficiary. So when a youth comes into foster care, you'll want to determine who's their primary care provider and if they're on a Medi-Cal managed care plan. If they are on straight Medi-Cal, consult with your CFT to determine what would be the benefits of keeping them on straight Medi-Cal or to enroll them in Medi-Cal managed care. Right? If they are on a managed care plan already, as a rule of thumb for continuity of care, keep them on that Medi-Cal managed care plan. If they were inadvertently switched off that plan, arrange to get them back onto that plan as soon as possible to minimize any health services disruptions. Remember, by law, they have a right to continuity of care even if plans got switched. If they don't have enhanced care management yet, enroll them in enhanced care management. Per timely access standards, remember the Medi-Cal managed care plan has 10 days once they determine that the youth is eligible to send it over to an ECM provider and then have an ECM lead care manager assigned to the youth. Then you'll want to find out the contact information for that lead care manager. You want to explain to the foster youth and their caregiver that they'll be meeting with the ECM lead care manager and explain in general terms what a care management plan is. Right. It's best practice because now child welfare social worker, you have care, custody, and control. You should be there when the youth and care provider meet with the ECM lead care manager to develop that ECM care management plan and then get a copy. Right. Make sure the ECM lead care manager is a part of the youth core health team and then invite them and or a representative from the core health team to the next and future CFT meetings. Identify who's on the youth core health team. If they have any special healthcare needs, consider asking the primary care provider to submit a referral to a specialist. Like if they have mental health issues, to a child psychiatrist. If they have autism or other issues, a developmental pediatrician. If the youth is hospitalized on a psychiatric or other emergency, reach out to the ECM lead care manager to see when they or someone else will take on the role of transitional care services, and then work with that TCS care manager to get a copy of both the discharge plan and discharge plan evaluation. If the CFT, which now should include the ECM lead care manager, determines that the youth needs a SRTP or CTF, determine if the ECM lead care manager or someone else will take on the role of that transitional care services care manager, right, to help them transition to and from the SRTP or CTF. If this SRTP is in another county, remember continuity of care and the youth primary care residents do not change Medi-Cal managed care plans. However, do coordinate to make sure that all the providers in that other county is aware of who the managed care plan of record is. It includes making sure that the local provider knows how and who to submit claims to at the managed care plan of record. About 6 months before jurisdiction terminates, meet with the ECM lead care manager to schedule a JT continuity of care coordination meeting that includes child welfare, the core health team, the youth and their family, and make sure that the youth and their family understands who will be their primary care provider and health insurer. Explain to them that their current primary care provider will help them with the continuity of care coordination, right? If they decide to move to another county or even another state, explain to them that the youth core health team will also assist. If they move to another county, make sure that they understand that continuity of care could continue and that the core health team can assist in making sure those medical records move. And then same with moving to another state, have the family identify what that health insurance is, identify even if there are managed care organizations in that other state. And again, that the current core health team can assist with getting those medical records, case management plans, and other things forwarded to the new core health team in the other state. The point is to encourage them to ask questions and to prepare for the transition. For adopted children, don't replace all the existing systems that are in place, but including working with post-adoption services, But in relation to health issues, including mental health issues, in addition to a call to post-adoption services, one of the first calls should also be to the youth primary care doctor and core health team. So in summary, Dr. David Satcher, who was a former Surgeon General, had a very elegant saying. He basically said, risk factors are not predictive factors because of protective factors. All those here in this presentation, your colleagues who aren't here, the foster youth, their families, they're all a part of this potential protective factors, right? This includes maximizing CalAIM for foster youth. If the youth is healthy, keep them healthy. If they become sick, prevent them from getting worse and heal them as soon as possible. If they have complex or serious issues or very high health risk, do everything possible to stabilize and maximize their health care and do it in such a way that they can be in their own homes. So bottom line, if this was your own child, how would you approach this? What matters to the foster youth and how can we help that youth, their family, and caregivers navigate their own healthcare journey? So just a number of resources here for you. My contact information.